Okay. So good morning. Yes. Okay. Good morning, Ahmedabad, and thank you for the invitation to be with you this morning, early morning in Jerusalem, Israel. And I would like to discuss in short the issue of bioprosthetic valve fracture for optimized valve-in-valve procedure. And it's a wonderful opportunity to speak after Dr. Parikh, who spoke about patient prosthesis mismatch and the issues of small valve, which is actually the harbinger for doing the procedures I will discuss in short now. Now, surgical aortic valve durability, as we all know, is age-dependent, and I'm speaking about bioprosthesis. It is age-dependent, with the risk of failure decreasing with increasing patient age. We know that durability may vary based on the valve model and, of course, on its size. There are many kinds of surgical bioprosthesis, whether they are the stented or the stentless bioprosthesis. They are all destined to fail in time of years. We are familiar, and let me tell you, as an interventional cardiologist, we got very, very familiar lately with the features, the characteristics of the surgical valve, and we know them very well now by their markers, by the height of the sewing ring, by their fluoroscopic identity, one may say. And in a short while, I'll go through how we tend to take care of these valves. Now, the valve may fail. The bioprosthesis may fail in different mechanisms, and they may, Dr. Parikh mentioned the VARC definitions for failure. I wouldn't get too deep into that. I will just mention that we may see either aortic stenosis or aortic insufficiency, or a combined presentation of both, and this may occur due to pannus, thrombus, calcification, wear and tear, or endocarditis. I wouldn't try to put a finger on what's the time to failure, but we know that the surgical valves would probably fail in 10 to 15 years in the optimal course. And we, as interventional cardiologists, in recent years may treat the valve failure not by redo surgery, but rather with implanting a TAVR valve, a transcatheter aortic valve, and this may be either one of the balloon expandable, the Sapiens, or the self-expandable, the core valve and the its new generation, the Evolute or the Evolute Pro. Usually, at least in my center, we tend to go with the supraannular Evolute, since it provides us with better hemodynamics. You can try, and different other valves have been tried as well, whether it's the MyValve, the Portico, and others. But we tend to go with the self-expandable and mainly the supraannular self-expandable Evolute. You need to get ready to prepare very well for a valve-in-valve procedures. You need to know the all the features, not only the fluoroscopic features of the valve, but its true internal diameter, the height of the post, etc. And this is now very easily provided by the wonderful application of, that you may find on your smartphone, which provides you with all these data, and the credit should be given to Dr. Vini Bapat, who developed this wonderful app. Now, TAV-in-SAV, transcatheter aortic valve implantation in a failed surgical, is a very effective procedure, clinically and echocardio, and by echo. Yet, there is mortality after aortic valve, mainly in the long term, and we know that this is related to mainly to the mechanism of surgical valve failure. Smaller valve and stenosis of the valve is a bad prognostic determinant. And the smaller the valve, and it relates very well to the previous presentation, the smaller the valve, the higher, the worse the prognosis is. And with small valves, we see high morbidity and especially high mortality. And this is because of the increased gradients, the patient prosthesis mismatch, and the Achilles heel of the valve-in-valve procedure is the residual gradient. We see it more with balloon expandable and less with the self-expandable supraannular valves. And yet, the smaller the valve, the higher the morbidity and mortality. And with that, I will try, due to the time limits here, to review how we do a valve-in-valve and what happens if we have a high gradient, and discuss the balloon fracture in detail. So here is a typical lady in our center, a 76-year-old lady, 8 years after a Magna 19. She had a small valve annulus to begin with, and the Magna that was implanted was a small one. Severe aortic stenosis, clinically functional capacity 3, mean gradient on echo 75 millimeters of mercury, and similar to the previous case, ostial RCA lesion that was treated prior to the valve-in-valve, and a low origin of the left main. You can go here through the CT analysis, a very small internal diameter, less than 16 millimeters, and low origin of the left main, and therefore, as you see here, before the final, we had a catheter protecting the left main with a wire and a stent on it, parked at the middle of the LAD, and before the final release of the evolute here in the Magna, we inject to see that it is open, and only then, being sure that there is no problem, no impairment of coronary flow, we release the valve without leaving, without leaving the stent in. The wire is still protecting even after final release. And you see here that we verify very well before we'll take out the wire from the left main. Taking out, this is the retrieval of the stent and the wire, which should be done in a very careful manner, not to leave a stent in uncrimmed, and a crimped stent somewhere in the aortic apparatus. And as you see, no coronary impairment, and surprisingly, probably because of the supraannular features of the evolute, no peak-to-peak gradient, so no need in any additional measure. And here we were already prepared for balloon fracture. But what happens if there is a gradient? And I'll go through cases when there is a gradient. Here, we need to fracture the, actually, although it sounds very scary or fearful, the best procedure so far, or the safer procedure, is just to break the ring of the surgical valve. And we do this with a non-compliant balloon, either a true or an Atlas Gold, a balloon with a diameter that is larger in 1 millimeter. We start at least with the 1 millimeter larger than the surgical valve internal diameter. We inflate until there is a sudden drop in pressure or an audible snap, and believe me, you can hear this snap, or just a visual fracture of the ring. The way this is done is by connecting through a three-way. We connect a syringe with diluted contrast, inflate the balloon, and then add pressure, getting to a very high pressure in this non-compliant balloon. There is, of course, a limit. We usually will do this with a supraannular with the evolute valve. You're always limited with the maximum recommended balloon size for the evolute that can be seen here. You cannot go higher than that without at least the potential risk for damaging the leaflets of the supraannular valve. And this is actually how this is done. Here is a 68-year-old gentleman, as you can see here, a very large BSA, an overweight gentleman that 9 years ago or 10 years ago underwent TAVR, surgical aortic valve replacement with mosaic. Residual gradient after procedure, a few weeks after procedure, was already 40 millimeters of mercury. And after, and he survives with that quite well, but yet underwent endocarditis with severe AI and then functional capacity 4. He had to undergo a valve-in-valve. And here, since he was a very high surgical risk at this point, we decided to go with a valve-in-valve procedure, TAVI. Here, since he had a residual gradient to begin with post-surgery, we did a balloon fracture prior to putting a valve in. You can see here the waist on the balloon prior, no waist, and we hear the audible snap, and just implanted a valve within. We couldn't see any break since there is no sewing ring, no visual radio opaque sewing ring with the mosaic. You couldn't see that, but based on the audible snap, reduction in gradient here, we knew that we broke well the ring. And following procedure, no AI, no gradient or very minimal gradient, and we could move ahead. And here is another gentleman, 87-year-old. That was this procedure was actually done less than a month ago with a perimount 21 implanted 15 years ago. So a very efficient procedure. He underwent the procedure when he was 72, but yet severe surgical valve degeneration with a mean gradient of 60 millimeters of mercury, mild AI, highly symptomatic, again, a bit overweight gentleman. And since he was admitted for pulmonary edema, he underwent the procedure quite immediately. Here are the valve features on CT scan. You can see here a very small internal diameter, about 19 millimeters of mercury, 19 millimeters, very large sinuses. So actually no major risk for coronary impairment following a valve-in-valve. And as you can see here, the LVOT is quite generous as well. No major risk for coronary impairment. VTC that is higher than 4 millimeters for both the right and left. Decent femorals. And here on the left, you can see how we do how the procedure is actually done. So now here we started with a TAVI. We put in an evolute, but since there was a residual 30 millimeters of mercury gradient, we couldn't leave that. So we brought in a true balloon, 20 millimeter. Remember the internal diameter was 19 prior to that, and I'll go again through the balloon, of course, under rapid pacing. Take a look to the right side, and we see that the waist all of a sudden is disappearing. And to prove that, we can even see here with the perimount, it's very easy to see the ring. You can see the break in the ring. And following this inflation, the gradient disappeared. Now, the procedure of bioprosthetic valve fracture was developed by Keith Allen in Kansas City. And in his initial series, he showed the efficacy of this procedure in reducing gradients and improving or increasing the mean valve effective orifice area. we should remember not every valve can be fractured, and the Hancock and the trifecta are the ones that cannot be fractured. Other valves can be at least remodeled. You can increase the ring just by inflating, and we know that now new valves are developed that can be intentionally fractured, so are kind of easy to fracture. But most of the valves, at least the ones that are implanted in my country, can be fractured easily, and these are the Magna Ease, and the Mosaic. There are some considerations to remember. Should we do the balloon valve fracture before or after valve implantation? Remember, when you do this before, there is no high pressure inflation of the implanted valve, no potential risk for the leaflets. When you do it after, it is done after we indeed verify that there is a gradient, that there is a reason to fracture the valve, and we do an optimal expansion of the TAV. And I would like to conclude describing in very short a series that was presented in TCT 2021 by Brinkman from Germany. This is a multi-center registry of cases that were done with either balloon valve fracture or not, about 80 patients in each group. And you can see here, it's very small valves. The true ID indeed was at the range of 19 to 20 millimeters. Most of the cases were due to stenosis. The mode of surgical valve deterioration was stenosis, with patient prosthesis mismatch rate quite high in both groups. Of course, the patient that underwent the balloon valve fracture were even smaller, more stenotic, and with more patient prosthesis mismatch. Most of the patient underwent procedure with a self-expandable, meaning the Evolute, as you can see here. About 80% of the cases underwent the procedure with an Evolute, with oversizing in relation to the internal diameter. Maximum balloon pressure in atmospheres was 15 atmospheres. This is high pressure. And as you can see here, post-balloon fracture, definitely a reduction in gradients, an improvement in the gradients. The procedure is quite safe. There is almost no mortality or adverse events related to the procedure, very low rate of VSD. One patient death, actually less than what was seen with in the control, and definitely more device success that is defined by the gradients than prosthesis failure is seen in the control group. The predictors for low gradient was post-procedure was indeed balloon valve fracture, the use of a self-expandable, meaning the Evolute, and the fact that no mitral flow. Mitral flow is not very friendly to this procedure or to the implantation of a valve within. So in conclusion, TAVI therapy for the generated surgical aortic valve is expanding in use and quite a successful procedure. Post-procedural gradients and patient prosthesis mismatch are associated with worse outcomes, and bioprosthetic valve fracture is a safe and effective procedure in reducing patient prosthesis mismatch, reducing gradients, and improving outcome. Thank you very much.
Thank you so much, Doctor.
Opportunity. Thank you.
Do we have any questions to Dr. HAIM? Okay. Thank you so much, Doctor. Really appreciate your time and insights. Thank you.
Excuse me.
Thank you very much.
Just one question to sir. Regarding the whenever we are talking about the regular this TAVI, at that time also we are seeing some annular rupture, and Dr. Ravindra sir has already demonstrated that. So what are the incidences when we are doing a valve in valve? At that time the annular rupture or such kind of a dehiscence if occurs, then how you manage it?
Very, very, very rare. I think it's a very few case reports of a valve in valve annular rupture. The surgical valve and the fibrotic process that occurs following actually are protective. And since what we are implanting in most cases is self-expandable, but even if you do a post-procedural ballooning and you do a balloon fracture, very rarely we would see an annular rupture. Remember, these procedures are done in patients in very, very high risk, at least until these days, and yet we see a very good prognosis, very low rates of annular rupture.
Thank you so much, doctor.
Pleasure. Thank you very much.
Thank you.
I have in last 3 years, I have had 2 patients post. One is native TAVI and one is valve-in-valve with PPM. Pardon, sir? Okay. In last 3 years, I have had 2 patients with PPM. One is native TAVI and one is post. So this PPM is being discussed, I think, only on paper, because when we plan for a TAVI, it's just feasibility and whether we can do it or not. And in both of these patients, BVF was not done. So as sir rightly mentioned, it's a very effective means. And rather, sir, the meta-analysis have proven that the chances of annular tear or dehiscence is lesser because the surgical valve gives a protection when it is done for native TAVI in comparison to valve-in-valve. So as sir rightly said, when we are going towards more intermediate and low risk patients, optimum result is best. Like the patient should leave the table with a single digit gradient.
Yeah, but his question was, if you do bioprosthesis, does that increase chances of
No,
perforation? That was the main issue.
So that rather all the registries and meta-analysis have proven that when you do a balloon valve dilatation in a native TAVI patient, the risk is higher as compared to when it is done for valve-in-valve. So rather it is protective. It doesn't increase, but the chances are less because the valve gives a protection against annular tear.
It is similar to the calcium fracture, more than similar phenomenon.
True. So rather it is more safer when you do in for valve-in-valve.
Thank you so much, doctors. Thank you so much, Dr. HAIM.
Thank you.